Good morning, Mickey.
Good morning, Steve.
How are you up there today?
Yep, I'm doing okay.
Good, good. Good morning to Millie.
Hi, Dr. Schumann.
Did you ever hear anything more about that cholinesterase or that pesticide claim?
Yeah, so the latest, actually, he has an attorney now. And it sounds like the people at the UCLA office thought there might be some connection too, but I'm not sure how it's going to pan out as far as is the whole work comp thing.
Yeah,
It's going to be a long drawn out process. And since he has an attorney now, it'll be a long process.
yeah. It'll be interesting.
Yes, yes.
Okay, well, why don't we go ahead and get started, and others will join us along the way. There was a case that let me get rid of my photos here. Of low back pain that came into the clinic that represented a couple of really interesting considerations. One having to do with etiology of the back pain. That was really the big thing. And the other is just how often or not often we see unusual causes of cases that come to our clinics. And what this was, there's a patient, why this case, why are we talking about this? So patient with a possible job-related condition, as well as non-job related aspects of impairment. And recall that in work comp world, when we talk about impairment, we're talking about any abnormality, physical or mental, with a patient. And so impairment is an important term. And why are we talking about this? It was a combination of job-related and non-job-related considerations that were a little harder to tease out than some of the others we've seen. Another point is we really need to be alert to occult disease. I don't know about you, but excuse me, when I was training, the comment was, well, when you hear hoofbeats, think of horses, don't think of zebras. But the fact is, we need to be thinking about the zebras from time to time, because there will be a percentage of a type of problem that we see relatively commonly that it doesn't always turn out to be what we think it is. So we just, we need to be alert. And let's go over this case, and I'll be interested to engage some discussion with you about what you think you might have done or what your opinion would be at several points along the way here. So I want you to put on your thinking caps. So the patient is a 54-year-old male, works as a truck driver for a local company that does ag support. And much of what they do is pesticide application. He spends part of his day driving tractor spraying, or he's on the ground spraying manually, depending upon the circumstances. And on 4/16/22 of this year, excuse me, he reported that some pain began after a field of doing manual work. And so the manual work would have had to do with hooking up equipment. If he's pulling a tractor, which he does a fair amount, has to do with walking around, spraying, and other excuse me, field tasks. He does have a history of chronic intermittent low back pain of unknown duration. He was a little vague about that, but said he had back pain off and on, didn't seem to really adversely affect his work, but he had it intermittently. His primary provider is Clínica de Salud, where he was being treated for hypertension and diabetes. So on 4/17/22, this is before we saw him for the first time, he went to a Natividad Medical Center in the emergency department. He was seen there for acute exacerbation of his chronic low back pain, but denied any known trauma or injury. So it started for some unknown reason, nothing specific. There was sharp back pain. These are from the notes in Natividad ER. Sharp back pain with any movement, particularly with walking. He denied fever, numbness, tingling, bladder or bowel incontinence, headache, changed hearing, vision, or leg pain. So no radicular symptoms. The note said, no acute distress, heart and lungs were normal, lumbar paravertebral muscle tenderness, forward flexion at the waist produced pain. There was no motor or sensory deficit. He walked with an antalgic gait, and the diagnosis was lumbar strain, and he was advised to take alternating Tylenol and ibuprofen for pain. So the next day, he went to the ER at Salinas Memorial. Excuse me. Complained of low back pain for 3 days since the date of onset. Reported a cough for a week. There was no trauma or injury. The Memorial ED note said no history of similar pain, but he was known to have chronic low back pain. He denied abdominal pain, chest pain, fever, or history of same. There was no numbness or weakness. On exam, heart and lungs were clear. He was noted to have lower bilateral lumbar tenderness on exam with negative straight leg raise. Neurologic exam was negative. So maybe it sounds like lumbar strain. And continuing that same visit, on the 18th, they did an EKG that was normal, did a urine was checked and clear. CBC showed a mild leukocytosis, and absolute neutrophil count was just over 9,000. Chest x-ray was normal. They did a CT scan of his abdomen and pelvis with contrast. That was negative. CT scan of the lumbar spine showed moderate degenerative disc disease throughout the lumbar spine with some disc bulging at several levels. Note was made that if there was, this was on the radiology report, if there was a high clinical concern for discitis or osteomyelitis, MRI might be attained for more detailed evaluation. A comment we periodically see. Clinical diagnosis, back pain, probably not a really helpful diagnosis because the patient already knew he had back pain. The question is, what was causing the back pain? So that was the diagnosis nevertheless. And he was given Flexeril and lidocaine patch or lidocaine patches for his symptoms. So 3 days later, then he came into Abbott, DOD Abbott. History was reviewed. Unfortunately, we didn't have access to either Natividad or Memorial's medical records at that point, but he was reporting what he was told. He said that the pain began on 4/16, the day before Natividad, after he spent some time in the field doing manual work. He described the low back pain as excruciating. He was noted to have substantial difficulty with ambulation. So he was having trouble walking because of the pain. With the understanding that imaging had really been negative, he was referred to pain medicine. And it was clear at that point that he was really in moderate pain. And that if the imaging was negative, then it looked at least like he didn't have a surgical condition. And so something more substantial other than just probably bed rest and some physical therapy was indicated. So the referral was made. So on 5/9/2022, several weeks later, the history between when he was seen at DOD and when he, and then this date, he went back to Memorial Hospital, excruciating back pain, and was diagnosed with L4-5 infectious discitis, Streptococcus galliticus, sepsis consistent with aortic valve infective endocarditis. And he was admitted to the hospital. So looking back on this at this point, what do you have any thoughts about what happened along the way? Could anything different have been done? How would you have managed it when the patient came into the clinic? Any thoughts about this situation?
Would it be appropriate to ask him about any history of IV drug use? along the way?
Yes, that would be a good question. Now, at what point would you have asked that?
Maybe just because there's no known trauma, pain of no origin that he could think of, ridiculous. I'm sorry, it was not radiating. It would probably be after his second ER visit, and most of the imaging was done. But I don't know. I mean, that's just one thing to think about.
Yeah, no, that's a good point. One thing that was interesting to me was in both the ER notes, when they said heart and lungs were normal, actually one of them even referenced no murmur was heard. If you had seen this patient and doing your normal good exam and it heard a heart murmur, what would you have thought at that point? Recognizing we of course have the advantage of retrospective evaluation. It's a whole lot easier to look at this when it's been done, and rather when they're in your exam room and you've got 5 patients waiting for you. And but what if you had heard a murmur? What would you have thought at that point?
Yeah, it would have been hard to put the correlation together, I think, but you have in the back of your mind, I would have to think that would there be some kind of potentially infectious thing going on? I mean, especially, if we were able to get the notes and know that there was a slightly elevated white count, that would have helped kind of put it together maybe a little bit easier.
Yeah, it's an issue of how high is your index of suspicion. And this is a toughie. I think I was the one that saw him. And he looked to me to be in a good deal more pain than the average low back injury that I saw coming in, 1 week post onset of symptoms. But he didn't look sufficiently dissimilar that I was really thinking, anything other than straining injury. There had, as I recall, we did get some x-rays and saw, the degenerative changes, but, it's hard to latch onto something here that would cause you to be thinking about something different other than there was a lot of pain. If he had not come into the ER, if he had not gone into either ER and he appeared in the clinic and he was in this much pain, I think what I would have done was send him to the ER to get a CT of the low back. They don't do MRIs in the ER, so get a CT. But we had the advantage of that, and that was negative. I wasn't, in retrospect, I didn't have the radiologist's report, so I didn't know that there was that comment about discitis or osteomyelitis. But in retrospect, we see some of these these phrases that most patients don't turn out to have these problems. So, but seeing that would trigger one's attention a little bit. But even knowing that, I'm not sure what the next radiologic move would have been made at that point if the discitis didn't show up on CT or MR early on. Well, CT early on. So probably the thing to do would have been to follow up with an MR at that point, looking for soft tissue injury. But, it's hard to say. I guess the point I would make from this is to say we do need to keep in the back of our minds, we always need to ask ourselves, is it possible something else is going on than what we think is going on, or what is most common that would be going on at this point? So, we ought to be alert to that. I don't know in general that we would be able to see this case and determine when he was seen what the problem was. I think it took the time to unfold, unfortunately. Just to follow up on this fellow, I've seen him now a couple of times since he was discharged, walking with a walker, still has a lot of pain in his back, where we are referring him to pain medicine. But now, with the diagnosis, the question is how to deal with the pain, not so much what's causing the pain. He's being followed concurrently by ID, infectious disease. And I think it's going to be a long time before he's anywhere near back to normal. So in the hospital, he completed IV, 6 weeks of IV antibiotics, and he's being followed. And he was going to follow up his family doctor for the chronic back pain. Now, here's the other part of this. And here are the comments. Could this have been diagnosed earlier? Not every injury is as it appears. Fine tune your index of suspicion. The other issue is there a relationship to work here? 54-year-old male who works, as I said before, truck driver, doing ag support, pain on 4/16, kind of a equivocal history, had history of chronic intermittent low back pain, unknown duration. He really wasn't describing it. It was hard to know really the extent of his pre-existing problem. So in addition to the most important thing about determining what his problem was then the other question that is asked of us is there a job-related component to this? And oops. Shoot. Is there a job-related component? That's a little bit tricky to answer. There we go. So is it new or is it pre-existing? And what's the relationship to his pre-existing problem? You recall perhaps that when we make decisions about job causation, the first decision is there a pre-existing problem? And was it really part of that? Or is it a new problem? Well, in this case, the question is that he had a pre-existing chronic low back pain. So now is what he's got, is it really part and parcel of that? Or is it a new problem? And when we make that decision, we're asking ourselves, if there's a pre-existing problem, did the new injury cause a material change in his condition? And what's our level of confidence that that's the case? And so when there is a new condition and an industrial event caused a material change, that's called an aggravation in work comp, magic word, aggravation. And that constitutes a new injury in work comp. If-
Steve, excuse me, Mick Joy.
Yes.
Was there conclusive evidence that this infection was work-related?
But no, in fact, that's the point I'm coming to. And that's exactly the question. You're right, Mickey, is, was it caused by work, or was it aggravated? Was it pre-existing and then made worse by work? And so the decision there is twofold. There are two aspects to that. Once we identify there's a pre-existing problem. One is, in the work comp world, an aggravation, that is making a pre-existing problem worse, constitutes a new job injury. And our responsibility then is to treat that condition, whatever it is, until we return the patient to what's called his pre-existing condition, which is that prior state of pre-existing back pain, whatever degree that was. On the other hand, if we see something as just kind of the waxing and waning of a pre-existing problem, That's called an exacerbation, and that's not job related. And if you look at our graph in the right lower portion of the screen, you see very lines that we've discussed before. And most injuries are the A graph, and there's at time zero, there's the whatever symptom, pain often rises to a certain level and then descends and returns to a zero baseline, and the patient recovers. The B graph is where the patient has an injury, but never whatever symptoms exist or physical findings never return to the pre-existing baseline. And so they become chronic, and the symptoms of the problem just never completely go away. And that symptom, and let's say it's pain, tends to wax and wane. It goes in the graph between 5 and a 6, back and forth. But there may be another injury to the back, and that is represented by the C graph. And you see there the symptoms, the pain, rise above the waxing and waning of the pre-existing problem. And this is where a new injury is determined, where an aggravation has occurred, and the difference in pain between roughly 6.5 and 9 on that C graph represents the new injury, and that's what we're going to treat. Now, how do you decide, as in this case, if the new problem represents an aggravation, that is a material worsening of a pre-existing problem and therefore a new injury, or not? And so the way we determine that is, sometimes you hear in the work comp world, well, all it takes is a 1% worsening or a 3% or a 10% or some other percent. But how do you measure that? It's a very difficult thing to measure. So what we do is we really look to symptoms or changes, measurable conditions. And so, for example, if the patient's pain following the event is materially worse, now this assumes trauma. This case, because the pain came from an infectious disease, that portion clearly was not job related. The discitis, the osteomyelitis it was developing, that clearly is not a job related problem. And he was determined, as mentioned, to have endocarditis. He was being treated for that. And that's a non-job related problem. But is there any element of this that would be considered job related? Well, if there's a material increase in symptoms that are due to something that happened on the job, it wasn't clear that that was the case, that his field work didn't clearly make the pain worse. In retrospect, it was the discitis. Was there going to be an alteration in work status if there had been a physical element to this of an injury? Change in pre-existing work restrictions, alteration in job assignment, increase in medication or therapy. All of those things happened, but they happened because of the discitis, not because there was something that happened on the job. Now, I'm not sure, I haven't talked to the adjuster, so I don't know how far into this work comp was really covering it. What should have happened was, once the diagnosis of discitis was made and determined to be the cause of his symptoms, the increase of his symptoms, he has pre-existing problem, but now that he's materially worse due to the discitis, clearly not a job related problem. At that point, this should be considered non-job related. And the treatment, the evaluation up to the point of the decision that it's non-job related would typically be covered by work comp. But then once the claim was denied, determined to be non-job related due to discitis in this case, then going forward, the treatment would be on a non-industrial basis. Now, is this something, many times we're able to make the decision or assist in making the decision. In this case, I'm not sure, frankly, where the decision was being made. We're still continuing to see him, but his management is really occurring with infectious diseases and the family physician. And my opinion is, and I would assume the carrier would come to this conclusion, is that what's going on once the diagnosis of discitis was made, it would be non-job related. So Mickey, you're right. There's no reasonable connection between his infectious endocarditis and what was happening in his back. So
Did the infectious disease specialist ever determine the port of entry of this bacteria?
I do not know that. I do not know that. Not sure. I'll have to go back and see if I can try. I don't have the ID report, but I don't have the answer to that. I tell you this, he did not look like a drug user. But what the cause was, there may have been some pre-existing valvular disorder. I'm not sure. So what's to be considered by this case? And actually, let me go on to say one other thing. Once we decide that, or once we observe that there's an increase in symptoms and we feel they're related to the job, then the second piece of this is deciding what's our level of confidence that a job-related event caused a material change in the patient's condition. And in the work comp world, significant words are probable and possible. And for something to be considered job-related, the industrial cause, the presumed industrial cause, needs to have in our minds at least a 51% likelihood based upon however we decide that. And if it's less than that, and we say it's possible but not probable, typically in the work comp world, that means it's not job-related. So what's the measure of probable? Well, it's anywhere from 51%, however you measure that, above. And if you get into the 90s, then or somewhere in that range, you would say it's certain that a job-related, the cause of the impairment was job-related. So we need to make two decisions in this, what's called AOE-COE decision, rising out of and in course of employment. In other words, is it a job-related problem? We need to make two decisions. Number one, if it's a new event, was that the only event that occurred? If there was a pre-existing problem, did the industrial event make it materially worse based upon that list that we just read on the last slide? So you decide, is there evidence that a job event made a material change? And then the second is, what's your level of confidence in that? If you're really uncertain, or you think, well, it's possible, but who knows, those do not rise to the threshold of confirming or making the decision it's job related. It needs to be in your minds that it's probable. It's more likely than not. And there's some other terminology that's often used. We say, in the absent the event of field work, there would have been no material change in the patient's condition. And the answer would be no. And what you're saying there is, if the field work hadn't occurred, would the patient have the symptoms or the physical findings or both? In this case, the answer is no, because clearly the problem was discitis related to seeding from infectious endocarditis. The terminology also can be used, but for the event of field work, there would have been no material change in the patient's condition. So the answer in using those words is no. We wouldn't use that phrase. Using the phrase constitutes probability. So those are words, those are sentences that the adjusters will recognize. We say, if this hadn't happened on the job, the patient wouldn't be how he or she is. And in this case, no. His pain was due, seemingly in its entirety, the increase in pain due to the discitis. So when you look at these cases, is this a new problem? Is there a pre-existing problem? If it's a new problem, was it the only cause or the most substantial cause? If there's a pre-existing problem, were the symptoms or physical findings, did they increase materially based upon, again, that list I had? And are you confident that it was probable that that industrial event caused the increase in symptoms? And at that point, we say it's job related. And in work comp, nothing is in concrete. That is to say, any decision we make, the carrier or the patient can get a QME and contest our decision. And that happens, moderately often. That's fine. And so we're just giving our best judgment. We're just making our best decision as to, in this case, or similar cases, is something job related. So you write that down, and then you send it off in the PR4, excuse me, the doctor's first report, or whatever other report you're writing, and that's your opinion. And then if somebody wants to contest it along the way, then they're welcome to. Any questions about that? Really very unusual. I've not seen this particular thing before. Okay, let's go on to another one. And I think similarly interestingly, there's a cerebral cortical abnormality on MRI in a firefighter. Firefighters, police, uniformed personnel of that sort, occupational sort, have what are called some presumptions, meaning that some things are automatically considered to be job related. And most commonly, cardiac disease, including blood pressure, respiratory disease, asthma, any chronic pulmonary condition, and a number of other things that are listed in the labor code are automatically considered to be job related. And we don't need to make an AOE-COE decision on those, because in the labor code, they're automatically determined to be job related. So here's a situation, and I'm curious how you might have handled this. Firefighter has evidence of cerebral white matter degeneration. Is there a relationship to work? That's the question here. So patient's a firefighter with a local fire company who was at work on 7/31/22 inspecting equipment when he noted dizziness, weakness, and malaise. He felt a little short of breath. He felt unwell. He was getting lightheaded. There were no palpitations, chest pains, or shortness of breath. Duplicate word. His blood sugar was checked at the fire station, found to be 66 milligrams %. After eating, and about 30 to 45 minutes later, he felt better. The blood sugar was up. They didn't tell us what it was, but it was up. He was feeling better, but he was taken to the ER. Good grief. Sorry. Bad fingers here. Whoops, good grief. Jeez. Yeah. Oh my gosh. I apologize here. We're having a little technical challenge. Okay, apologies. That was not cool. Taken to the Natividad Medical Center. CBC showed an RBC count that was a little low. Had a history of low or borderline RBC, and they did an MRI of the head that showed minimal, chronic, non-specific white matter disease. He was grief. Oh, man. I really apologize here. So after the ER, he was directed by his employer, the fire department, to a local urgent care center not related to DOD, where the provider told him that his condition was not job related and he was developing Alzheimer's disease. He was instructed to follow up with his family physician. Any thoughts about that conclusion? Well, I would say that's a tough conclusion to come to. Number one, I'm not sure that in most of the urgent care clinics, whether it's DOD or otherwise, we'd be able to make the decision of developing Alzheimer's disease on that bit of information. But he was told that it was not job related and he was going to follow up with his family doctor. Understandably concerned, the firefighter sought care at a local DOD urgent care facility where the provider opined that a causal relationship between white matter degeneration and fire smoke was not clear. Patient was referred to a neurologist. The following day, the adjuster contacted the DOD facility and reported that based upon the information from the first urgent care clinic, the claim was denied as industrial. So it seemed that there were three choices in speaking to the adjuster as to how to manage this. And those three were concur with the other urgent care provider that it was job related, consider the claim to be non-job related, or to recommend to the carrier to put the claim on delay, send the patient to a neurologist for a definitive evaluation and opinion. Which of those would any of you have selected when this situation arose?
I would have picked number 3.
And why not one of the other two, Mickey?
Well, like you pointed out, the first decision, I think, was a little premature and there wasn't any basis for making that. And I don't know that we have a clear answer as to whether or not his condition could be related to smoke or other job-related injuries, such as traumatic brain injury, concussions, things like that. So until we get a little better clarity on cause and effect, I think you put it on the delay and let the neurologist help you sort it out.
Yes, and so the discussion with the adjuster was had on that subject, and that recommendation was made. Adjuster said she would take that under consideration, but thought it would be difficult reversal. I guess once the adjusters make a decision that they deny a claim, even in the presence of additional information or guidance, it's apparently difficult to reverse that. And so she called the next day and said that the claim was denied. And the patient actually was lost to follow-up. I suspect he went to his family doctor. Most of the time, when you think back on the last patient we just talked about, making an AOE, COE decision, most of the time we're able to reasonably conclude that something's job related or not job related and make that opinion, that AOE, COE decision. But sometimes there are conditions that are unclear, that are in the gray zone. Job stress is one. But this kind of case, I personally was reluctant to conclude either way. I did a quick update search before talking to the adjuster, and I couldn't find anything, although it was not an extensive search. Couldn't find anything that really drew a relationship between smoke smoke was what I was really looking at, and degenerative brain injury. It may exist, but just on first rough glance, it didn't appear. And so, but I just didn't feel comfortable making the decision one way or the other. And a decision really needs to be made because the firefighter was really quite anxious about this, believing that he was in the process in his, I think he was in his 40s, that he was developing Alzheimer's disease. So he really did need to get plugged in with a neurologist. Now, here's another interesting aspect to this. The claim was denied. What do you think about the low red blood cell count and the low serum glucose and the patient's original complaints? So recall that he had an episode at work of dizziness, lightheadedness, weakness, kind of malaise, not feeling well, that seemed to respond to, maybe responded to eating. And he had a history of mild anemia, low red blood cell count. What do you think about that in relation to this case?
Could he be having episodes of hypoglycemia over time, causing some of his symptoms?
Well, it certainly sounded, the evidence suggested that he had an episode of hypoglycemia, and that perhaps caused the symptoms that took him to the ER. So what took him to the ER? It was those symptoms, and then along the way, an MRI, a CT scan of the head was done, and he was felt to have the degenerative changes. Now, what relationship, do you think, given this information after the fact, what relationship did the findings on the CT of the head, what relationship was there between that and the patient's symptoms? Millie, what do you think?
I'm not really sure about the causation of that. I mean, as far as the dizziness and the other stuff, I'm not sure that would relate necessarily to the head CT and the sugar. Not sure.
Right. Yeah. In fact, even if there wasn't the history of low blood sugar, I would be hard pressed, I think, to conclude that those symptoms were related to chronic, mild, or is the terminology minimal, degenerative changes. What's going on here is really there are two scenarios, medical scenarios happening. One is the patient went to the ER because he was having lightheadedness, which, because it occurred on the job, and particularly among firefighters, the definition of job relatedness is quite broad. That would be considered job related. And so the presumed hypoglycemia, in the absence of other good explanation for that, would be considered job related. And his symptoms resolved, and the ER didn't find anything else other than these cerebral changes. Then there was the serendipitous finding of abnormal cerebral changes, and that was a coincidental finding to what the original claim was. So appropriate management would be not to deny the claim, the medical claim of why he went to the ER. It would be to accept that, and that he recovered, and that he returned excuse me, to his baseline status, graph A in that graph. He became symptomatic, nothing more. It was a single episode, but incidentally, this finding was noted, and that would be concluded to be not job related, probably, but equivocal, and sent off to the neurologist. So in fact, what one could reasonably do is say that when he came into the ER, that to accept the claim, but to say that serendipitous finding was probably not job related, but refer to the neurologist. And then the carrier would have the choice of either paying for that visit, which they sometimes would, to get a definitive statement from the neurologist, or tell the patient, the claim was denied, you need to see your family doctor, be referred to a neurologist. And then if something down the road appeared to draw a relationship between those symptoms and his abnormal CT, then one could reopen the claim. So I would say the original problem that took him to the ER was not job related, and there was an unusual finding. Oh, excuse me. What took him to the ER was job related. That is the dizziness, probably related to hypoglycemic episode. But the abnormal findings, more likely than not, were not related, and that on some basis he should see a neurologist. And whether that happened through work comp or not would be a decision the adjuster would make, rather than just denying the whole claim. So again, what we're doing in this, and this is really applies to non-industrial situations where this kind of event or situations occur when there is a serendipitous finding, something we weren't expecting to see shows up, and then we manage it. And sometimes patients come in complaining of something, and then we find something else, and then we need to manage that. And when there's an issue of causation, then we need to parse this and determine what relationships exist. So what are the patient's options? Again, I think he really needs to see a neurologist on some basis, and let the neurologist make a decision about what the cause, if it's identifiable, of his cerebral degeneration is, and then what to do about it. Any questions or comments about that? Let's go on to one last one here. And this is one that produces some questions related to work and continuing care and responsibility for that I see coming up in the clinic from time to time. There's a patient who lost her job, but had not yet recovered from her injury. And what happens then in the work comp world about this? What happens to a claim with a patient who loses her job? What happens when that patient has a new injury with a new employer, if that should occur? How do these get managed? So Maria, in March of this year, housekeeper at Motel 6, where she was making a bed, she stepped backwards to adjust the mattress. A coworker walked behind her, and the two tangled feet, causing Maria to fall to the floor, landing on her right shoulder, hitting her right wrist, resulting in pain in both body parts. 3/28/22, Maria was unchanged with right shoulder and upper back pain, described as 10 out of 10. Pain felt better with the wrist splint. And she was treated symptomatically with analgesics, muscle relaxant, and light work. She reported that unfortunately, her superior was not honoring the lifting limit, and she was honoring the lifting limit, but she was also having to push and pull heavy containers of linens for laundry, particularly pulling sheets out of the washing machine, which was exacerbating the pain. So they were honoring the lifting limit, but the portion that said no strenuous work was not being honored by the employer. In the next month, April the 11th, she was largely unchanged. Pain continued in the right neck and upper back, as well as right shoulder and right wrist. She continued to have difficulty pulling sheets out of the washing machine. Unfortunately, the employer had not yet submitted the employer's first report of injury, and the claim had not been opened, which is sometimes a problem, as you recognize. And what do we do about that? Well, the patient, if we can't get a hold of the carrier or the employer in those cases, then we tell the patient they really need to speak with their employer. And if they've got somebody in HR, talk to HR, because there's nothing in work comp that can be done or that'll be paid for until the claim is opened. In a work comp case, there needs to be the doctor's first report. Well, patient needs to fill out the DR1, which is their report of thought to be injury, which doesn't constitute an acceptance of injury by either the employer or the carrier, but it's the patient's report. Then the employer fills out the employer's first report, sends that to the carrier. Physician, the provider fills out a doctor's first report, that goes to the carrier. So for the carrier to open a claim, it takes both the doctor's first report and the employer's first report to be present for the carrier. And then they open the claim and give it a claim number. And so for anything that is to be done that requires payment, the claim has to be opened. So it ends up delaying, particularly oftentimes the patient getting medicine, and for sure getting into physical therapy or doing anything else like that. By May, patient was unchanged. Marie was unchanged. She was doing light work, including changing 30 beds a day. Finally, the claim 2 months later was opened, and physical therapy began shortly thereafter. Had several visits by that date. She wasn't getting any better. Physical therapy wasn't helping. MRI of the right shoulder showed moderate supraspinatus tendinosis, as well as the same in the infraspinatus and subscapularis. There was mild subacromial deltoid bursitis, degenerative fraying of the superior labrum, and mild tendinosis of the long head of the biceps tendon. So there was a fair amount of pathology in the shoulder. She was referred to an orthopedic surgeon, but the carrier hadn't responded with authorization at that point. Now, here's where it got a little bit tricky. Excuse me. Patient had contracted COVID-19, and so her doctor had taken her off work. So she was off work, but continued to complain that she was no better in spite of that. And then on the next visit in August, on the 10th, she indicated that the motel had been sold to a large hospitality chain or another hospitality chain, and that all employees are being terminated, and that if they wish to retain employment, they would need to submit an application as a new employee. And in many situations, this is not uncommon. When companies are sold, they change hands, then the new employer wants to have the opportunity to determine who they're going to keep rather than just accepting all employees. Sometimes that happens, sometimes it doesn't, but it did in this situation. So now here's the patient complaining of symptoms, presumably, or at least reportedly, not getting any better, doesn't have a job at this point to go back to until she submits her application. And what's the likelihood with her on partial disability, she's got work restrictions, what's the likelihood that the new employer is going to hire her? Maybe not great. So her motivation to return to regular work was questionable because she had lost her job. So at that point, excuse me, it becomes really difficult to judge the extent of patient's symptoms when the patient knows that as soon as she's recovered, presumed to be recovered, she's going to not have any disability payment and no job, presumably, to go back to. So what happens to a claim when a patient loses his or her job? What happens, and we've had some of these, when that patient goes to a new employer and has a new injury with a new job, a new injury with that employer. And then sometimes it happens, not in this, but the question is, what happens to patient care and wage replacement at the end of a temporary work season, specifically seasonal ag work? October rolls around, November rolls around, the picking season's over. Those folks working in the fields that have an injury, can't do their regular work, seemingly can't get a job with another somebody in the off season. What happens to them? So what happens to a claim when a patient loses his or her job? Anybody know the answer to that?
The claim stays open, as I understand it.
Yes, that's exactly right. The relationship at that point then is between the patient and the carrier. And so no matter what the patient does subsequently, gets a new job, loses that job, gets another job after that, whatever, it moves to a new state. The claim stays open until the patient's determined to be by the provider MMI, and then the claim is settled. So in a situation like this, no matter what happens to Maria, that claim's going to stay open until the treating doctor determines she's MMI, maximally medically improved, medical term, also permanent and stationary, administrative insurance term. So she'll continue to be treated no matter what happens with a new employer or not. If she doesn't get another job, she continues to be treated. And she would continue to get wage replacement until she's determined to be MMI. And then disability stops, wage replacement stops. So she'll get whatever she was getting with wage replacement, and she'll continue to get treatment. Now, if Maria had gone to a new employer with a new job and had a new injury along the way, either the same body part or a different body part, what happens there?
Is that before she was ever determined MMI?
Let's see, hypothetically, yeah, she hasn't gone to a new employer, but excuse me, let's say she did and had a new injury while she was continuing to be treated for her old injury. Let's say that she has now a new injury that's a knee injury while she's being treated for the shoulder injury. So the shoulder injury is the old injury, the knee injury is the new injury. What
It
happens?
becomes a new injury.
I'm sorry?
It becomes a new injury.
The knee is a new injury, that's right. And she's treated by wherever she's sent by that employer. And sometimes, excuse me, they would come to us, and sometimes they would go to a different clinic or a different provider. So there would be two open claims. They might be with the same carrier if the two employers happen to have the same carrier, or they might be two different carriers, but two different claims. And when we see those patients, we treat them as totally different events, and we treat them on different days. So we wouldn't have somebody generally, sometimes it depends on the circumstances, but generally we would treat those as if they were in fact two different patients, two different events. And care would go on for both of those until either or both were determined to be maximally medically improved and the patient recovered. Now, what would happen if Maria went to a new employer and had a shoulder injury with the new employer, and now instead of her pain being 5 out of 10, it's now 8 out of 10? What happens to that?
I'd say that's an aggravation of the older injury.
That's exactly right. It's an aggravation. And if you think back to the graph, that's line C, where the line B had been the pain kind of waxing and waning, not going away, and now it's materially worse. And the treatment for that aggravation is going to be getting the patient to what state?
To her previous level.
Yes, pre-existing condition. Now, what is the carrier for the first injury going to say at that point? I'm sorry, well, before they get back, they've had the new injury, now they're worse. What's the carrier going to say? Carrier for the first injury.
Wouldn't they likely say the new carrier will take over the case at that point? Or would you have two cases on the same body part with separate injury dates?
That's an excellent question, Danny, and that's right. And so the answer to the first is yes. Oftentimes the carrier will say, hey, this is a new problem now. See your new employer and the new work comp carrier. The second is only very rarely have I been asked to manage two injuries to the same body part, which is a nearly impossible task in my mind. And unless there was one that came up at Memorial, I had to manage because they were both hospital, but they wanted to do them as two separate claims. But other than something really unusual like that, I just tell the patient and I tell the patient, we're going to manage one injury here. And in this case, it's going to be the second injury. Now, what is the carrier for the second injury going to say? Sometimes what they'll say is, hey, this is really just a continuation of your pre-existing problem. We don't think that anything new really happened here. Now, how are you going to make the decision and tell both carriers what is your opinion? How are you going to make that decision?
I would usually just say that I believe this is part of the original old injury, and if there's a dispute, get a QME.
Yeah, that's certainly one possibility. In terms of deciding if a new injury has occurred, what I would do is you look to that list. Was there a material change in symptoms or physical findings or treatment? And if there was a material change in any of those, then you're on good ground to say, this is an aggravation, new problem. We're going to treat the aggravation and try and get the patient back to pre-injury status. And then when that happens, then decide what to do about the first injury. What's the point here? The point is, when you have this kind of thing happen, then you treat one injury and get them to whatever state is appropriate. And then you're right, Mickey, if the carrier, the employer disagrees on either side with that, then they can get a QME. But you want to keep these as simple as possible. You want to decide, has a material change occurred here? And how confident are you? Confident is 51% or more? Is it more likely than not that this really constitutes a new injury as an aggravation? Treat that and don't worry about the first one until you get the patient back to the pre-injury status on the second injury. Sometimes these get a little bit muddied and hard to decide. And if you come across this, I know I'm happy to talk to you about it. I'm sure Dr. Price would be happy to talk too. But feel free to call. It's 8 o'clock. Let me ask one last question. What happens, and this happens fairly often, to a patient? Let's say Maria had been working for an ag company picking, and now the season was over, or let's say it's over. The seasons are about to be over pretty soon. And so she's going to lose her job. What do you tell her about if she's going to continue to get care and if she's going to continue to get wage replacement? Well, I'll give you the answer. You would tell her that she'll continue to get care because she's not yet MMI, maximally medically improved. Wage replacement, typically the way the carriers for ag companies do is, if the injured employee can show evidence that in the past they have worked in the off season. Now, sometimes this gets a little bit difficult because it takes pay stubs or some other evidence of having worked, and they have an income during the off season, and now they can't do whatever job that is that they usually do and won't have a job, then they'll continue to get wage replacement. If they don't have evidence of that, and many of these folks just take a break and don't work in the off season, then the wage replacement will stop. The patient care will not stop, but the wage replacement will stop. I don't generally get into that discussion with a patient. What I do is I tell them, talk to your carrier and see what's going to happen. But that's the answer to that. So there is an opportunity for those that go on to do something during the off season, and they'll continue to get wage replacement. Okay, well, we'll wrap it up. It's 8 o'clock. I guess the thought on this third case was, it's valuable to learn as much as you can about the patient's circumstances, both on and off the job. Sometimes there are confounding elements, things going on, circumstances related to the job, maybe they're losing their job. Or we've talked about cases in the past where patients have had family difficulties or something else that makes it desirable for them to be off work and to be considered disabled. What we have to do in work comp is just really follow the rules. And the issues that we have to consider are what's going on in the job. Unfortunately, it just is not something that we should be doing, to be looking into social situations and make decisions, particularly about work relatedness, disability or not, on or off work or not, based upon family circumstances. We can be sympathetic and try and be understanding, but we have to make decisions about can they work or not based upon their condition, what they can do with restrictions, and what the work situation is. So keep that in the back of your minds. All right, thank you for your time. If there are any questions, let me know. Please keep sending me cases. A lot of what we talk about now are great cases I'm getting from DoD providers. So send me your cases, and that continues to be very helpful. All right, all, have a good day. Enjoy yourselves.
Thank you.